you to today's experts. Dr. Timothy Putnam started his career in healthcare in 1983, doing surgery research in Cincinnati. This work was expanded to include administrative responsibilities in the 1990s at hospitals in Georgia and Indiana. Dr. Putnam's first CEO role was at Mercer County Hospital in Aledo, Illinois, and is currently CEO of Margaret Mary Health in Batesville, Indiana. He has a doctorate in health administration from the Medical University of South Carolina and an MBA from the University of Southern Indiana. Tim holds board positions in several organizations, including Indiana Rural Health Association, Indiana Hospital Association, American Hospital Association Regional Council, and the Cincinnati Health Collaborative. He is currently board chair of the National Rural Accountable Care Organization and chairman of the National Rural Health Policy Congress. Angie Charlotte has over 20 years experience in both large healthcare institutions and small rural critical access hospitals. Her clinical background includes experience from frontline care to senior leadership. Her quality background has mainly been in operations with a focus on ancillary departments and physician practices. She is Lean Certified Six Sigma with successful implementation in process improvement in productivity and waste elimination. Angie received her master's in healthcare administration from Bellevue University and is currently pursuing her doctorate in business administration with a focus on healthcare executive leadership. Her focus has been on patient safety and quality efforts in both rural hospitals and clinics for Illinois and beyond, as well as implementing the Medicare Shared Savings Program, ACOs care coordination, and patient-centered medical home implementation. She recently held the past president seat for the Illinois Organization of Nurse Leaders and is board member of the National Association of Rural Health Clinics. Angie is currently the Director of Quality and Education Services at the Illinois Critical Access Hospital Network, or ICANN for short. Sally Buck, CEO of the National Rural Health Resource Center, will facilitate today's discussion. Now I will turn it over to Sally, Angie, and Tim. To unmute your line, press *2. Sally? Thank you, Kim, for the introduction, and welcome everyone to joining today's Performance Management Group call for the Small Rural Hospital Transitions Project. And we're really excited that you've all joined today as Tim and Angie have firsthand knowledge and experience from a hospital network perspective of adapting to value-based models and beginning to adopt population health strategies. So we're excited to hear their perspectives. And I will be posing a series of questions for them, and then we'll open it up for questions from all of you at the end, either through the microphone on your phone, or you can put them in the chat box. So our first question is, what are the most compelling reasons for rural hospitals to adopt value-based models in population health? And I'll start with Angie on this one, and from certainly the network perspective that you have with your critical access hospital members. What are you seeing as the reason ICANN has moved forward in this, Angie?
Can you hear me?
Yep.
Okay. So I think for us, it really boiled down to the healthcare reform. Triple Aim, the push for clinically integrated networks. We were seeing more and more of the navigator programs and coordinated care programs. The focus on primary care-driven reimbursement really started to show itself here in Illinois. Our hospitals wanted to remain independent, and in order to do so, they were looking at strategies to do that. So that was really the most compelling reason for us to move forward in this ACO venture.
Thanks, Angie. And Tim, from your perspective?
You know, at our hospital, it was just a little bit more visceral than that, I guess. You know, we saw the changes in the marketplace, but I will tell you, it stems from a discussion that our board of directors had over 2 years ago. And first I must tell you that like many of the hospitals on the call, we're very mission driven. Our mission is to serve our community the best way we can. We were formed in the early 30s during the Depression. The community came together to build the hospital. As a matter of fact, our name, Margaret Mary, are named after two ladies that never lived to see the hospital completed. So there's a lot of history. People know the history and know what we're for. And there was a discussion that was held at our board of directors, with our board of directors a couple of years ago in a retreat. And basically it said the way we treat patients today, if you're a diabetic patient, and this was a gentleman explaining what happened to his grandmother, said, you know, we're paid to see you in the office. We are paid to diagnose your issue. We're paid to amputate your toes. We're paid to amputate your legs. And we're paid a little bit to get you a wheelchair, but we're never paid to keep the disease from progressing. We're never paid or incentivized in any way to keep the disease under control. We are not financially benefited at all if we treat that diabetes without doing something significant like surgery for it. And our board basically sat around with leadership and said, that's not what we're about. That is not what we want to be. We realize that's the payment system of today, but we want to be for our community what they need to be, not the best way to get financial success of the organization. It is about serving the community, and so that's our main goal. How to do that and how to incentivize that, because we shared with the board, if we do that, if we put all of our efforts toward wellness and keeping the amputations on the diabetic from happening, we will go broke doing that, because we would shift all of our efforts and incur a tremendous amount of cost toward wellness while at the same time cutting our reimbursement, and we would not be able to be sustainable in our community for that. So they charged us with finding a way to be able to achieve that goal of patient wellness and the benefit for our patient without going broke doing it. So that's what motivated us to look at these types of models and get involved in it as aggressively as we could.
Okay, great. And I guess before we go to the next question, is population health is often looked at with two different focus areas. One is looking at a specific group of patients or patients covered under a certain payer or cohort management type or chronic disease, or it's looking at the total population of your service area, of your county, and that's geographically defined, or you know, your own employees and their families. How, I guess, which perspective, as both of your organizations started down this path, was there a one of those definitions or models you were aiming at more specifically? I'll start with Angie.
I was afraid of that. As he laughs. When we started down this, we were really looking at the Medicare Shared Savings Program. We actually, when it all began, it was originally 6 hospitals looking at trying to share some services such as orthopedics, when it was very difficult to get an orthopedic surgeon in there. So we were looking at cohort management, yes, in that specific process, but it really began to look at the total population service. And while we're not fully geographically defined yet, it's coming. We are really looking at population as a whole, for all of our participants, and we will be drilling down into cohort management by disease diagnosis based on the attribution list that we receive from CMS. So we're a blended mix, and we're also looking at some payer models with Blue Cross Blue Shield. They offer an intensive medical home model of care management, and so we're going to be working with them. So we do have that blended mix in how to answer that whole population health. On the flip side, since we began this journey, we also developed a wellness committee, and we're looking at just our employee wellness as a whole in what we provide for them and how we can improve the well-being of all of our employees. So we have several legs that we're traveling down in this journey.
Mm-hmm. Okay, thanks, Angie. And Tim?
Yeah, I think Angie described it well. It's a journey. Whether you start with Medicare shared savings, which is what we did, and we've expanded to a group of insured patients with a Blue Cross product to include them as well. We don't want to just serve a segment of the population. We want to be able to serve the population as a whole. So it's bringing our whole team up to speed on how to focus on wellness. Even though we're incentivized right now for these insured patients and for the Medicare patients, we know it won't stop there, and we're trying to turn our entire organization toward that, where there will be advantages, wellness programs. Now, I will tell you the disease processes we're focused on, COPD, CHF, diabetes, are lean more toward an adult or geriatric population, but we won't stop there, and these are just the first steps down a journey. I know there'll be a lot of pediatric applications in the future. I know there'll be things like that. So it's just looking for a way to get started and getting your team to think about focusing on wellness as opposed to treatment of injury and illness. But it is a long journey. It's a long continuum.
Okay. And the next question, what are the reasons for rural hospitals to be cautious moving into this model? I'll start with Tim on this one.
I figured it was my turn. Yeah. My chief financial officer reminds me we still get paid to do stuff. Much as there's talk about changing the incentives and changing that, we also were told early on, as we were early adopters in this process, that the hospitals that have gone down this road very hard have eaten through their cash reserves doing it, because you spend a lot of time, effort, and money developing programs that have no financial return. So this is not for someone that's trying to survive and not sure how they're going to cover payroll over the next couple of months. This is long-term. The Medicare Shared Savings Program, for example, it'll be iffy whether we get shared savings the first year, and quite frankly, doubtful. Okay. So we're putting a lot of effort into it at this point in time with the limited returns potential for it. If we are successful, though, and we do reduce costs, then we will see that return. But the financial has to be the first concern. The other is you've got a lot of people invested in the system the way it's delivering care today, and I think they really have, they're convinced they're doing good things for their patients. So you are changing things in their lives. So the physicians are always in the do no harm stage, and even though we're talking wellness, we think it's a good thing. This is a change, and it's something that not everyone will be comfortable with right off the bat. So there is that cultural thing that can take place in your organization as you start to make moves like this. I mean, you are getting into the business of the primary care physicians in their office, and they've got pretty strong feelings about how they take care of patients in their office. So those are the two things we've seen as far as cautions. They're not things that can't be overcome, but you have to realize those are challenges.
Sure. Okay.
And I'm going to tag right onto that. Tim did a great summary of the same things that we're experiencing, and we're still very early on in this phase. And I think, you know, jumping into something that you have no idea what it's going to produce, that fear of, and taking that leap of faith to do that is very challenging and very difficult for many to take on. And really focusing in on that provider engagement, because change is hard for a lot of people, you know, and looking at that, you know, are they willing to adapt to change? Are they able to take on new responsibilities, and the way they've always done things is changing around them in both their practice settings as well as the way they're doing things in the hospital. You know, the way they go in and round on patients is a little bit different than what they've been used to in the past. You know, they're working with a deeper set of care management skills with their nurse care managers versus what they've done in the past. And I think while it's not cautious in moving into it, it's that realization that it's not an easy step moving forward. So, and still unknown what that financial gain is for you in the end. And then when you're looking at all your data in the end, you know, what have you learned from that? Because we're not there yet, whereas Tim is a little further advanced than us. So he really did a nice job.
And have you both seen that since there are challenges or concerns that this has, that you've been able to do this because of the partnerships, or like Tim, that you're part of the National Rural ACOs, so you're with other hospitals? And
yeah, I mean, it was simply due to the fact that within our system we were assigned 2,300 lives, and at our hospital. So we couldn't do it on our own, since Medicare just basically said, if you don't have 5,000, you can't do it. So for the Medicare Shared Savings ACO, it's a minimum of 5,000. So we had the group together with other hospitals. And we talked to hospitals in our area, and none of them are really interested. So our group, the national group, they're hospitals from Michigan, California, Indiana, that all kind of had the same mindset. We all felt we need to go down this direction, and we band together. So before, we'd never even gotten together to talk. So now we're band together as this ACO, and I tell you what, people across the country are looking at us going, well, how does that work? How do you do it without a tertiary partner? How do you do it without having even known each other? Why do you have faith in, you know? And it's just a way to share costs and be qualified for the program. However, what we've received out of it, when we look at the data by hospital and by provider, it's surprising what we learned from our California cohort and what we learned from the folks in Michigan, and what we're doing that's compared to them. So it's allowed us to compare and contrast stuff we never would have talked about, and open doors of solutions that we wouldn't have considered before, because of how the environments they're in, how they've got to accomplish things. And it shows in the cost of that.
Okay. Thanks, Tim. Angie?
Sure.
How has the network helped your hospital?
Yeah, ours has been network-driven, but I do want to say that the national organization and the resources that they have provided for us to really, you know, take that leap of faith and step into this has been phenomenal. So even if you're just kind of touching on it, you know, seek out the resources that they provide to look at that. But for us, we had that network. We had those original 6 that said, hey, let's do this. Again, looking at that 5,000 lives, we didn't meet that yet, so we were looking at ways to open this up and open it up to the entire network. We have 53 in our network here in Illinois. And, you know, discovered that, hey, there's a lot of other people out there that really want to do this collective approach, and learning from each other and sharing the resources. They've realized it's very difficult to do it alone, and what can we do, you know, collectively together, both at the local and regional levels, as well as the state levels. So that's how we started. So ours is a little bit different, but very similar.
Okay. Thank you. Well, now getting into some of the solutions and more specific, we'll start off with sharing a few tips or lessons learned concerning quality and leadership within your organization to move towards value-based care and care coordination.
And I can take a stab at this one first.
Okay.
This is Angie again. So what we did was we created a hospital readiness assessment tool. And it was really to help folks prepare for care transitions and population health management. And it was designed with a focus on 6 key areas in governance and leadership, operations, patient care management, population health, disease management, quality, and the IT infrastructure. And that really kind of gave us ideas on what everybody needed for resources and, you know, the areas of concern that they may have. You know, what is it that they may or may not have in regards to quality? Were they really actively utilizing a quality improvement program? You know, did they understand the data they had? What were they doing with the data they had? Were they sharing it with the board? Did the board understand that? You know, looking at leadership, did they understand what care transitions was, what population health was, you know, stepping into their mission and vision, reevaluating that? Was it aligning with population health? Really embracing the change, looking at some areas that they could target in the community. You know, was it palliative care, preventative care, wellness, you know, curative? You know, really starting to dig into what they knew, what they didn't know. I think that is, you know, definitely that first line of my tips is really looking at what do you have in place, what do you know, and what don't you know, and where do you need to build in that gap. For us, that was a big eye-opener, you know, even looking at that financial engagement. You know, were the CFOs engaged in this? Did they understand that this is going to take up time and resources, you know, and how they prepared their budgets?
Okay. And I take it that readiness assessment looked at all aspects like HIT, finance,
yes,
community partners.
Yeah, it really dug in. It actually even digs into your community health needs assessment. What did you do with that information? You know, we were finding some of them do the community health needs assessment once every 3 years, and that's all they do. They didn't follow up. They didn't continuously utilize that information to improve their market share in their community. You know, so again, it's just, it was very valuable in really assessing where you're at.
Okay. Andrea, would you be willing to have us share that with the group?
Yes.
Okay, great. So we'll get that as a PDF, and we can share that with the participants following the call. That'd be great. Okay, Tim, how about from your perspective, your top tips in terms of quality or leadership or care coordination? You can touch on all 3 or just one of those areas.
I'll touch on a couple. One, I follow up on Angie's statement. I think it's important when we're talking about small hospitals like ours, and especially if you're part of a network, to create a shared dialogue, a shared vernacular. What do we mean the same thing by care coordination? What do we mean by quality metrics? And I think it was getting everybody on the same page so we're all looking at the same type of thing, and that was really important. I don't know if you guys realize that people in Michigan don't speak the same language as people in California. And that's, you know, we had to sort of get on the same page, and what does this mean, and that was a big piece of it. Care coordination is sort of a different thing that we're still taking shots at it, but we're not quite where we feel we've mastered it yet. We're not sure what the skill sets are that make somebody a great care coordinator. I don't know whether, you know, we looked at initially being a nurse practitioner, Now we're using registered nurses, but I don't know whether it'll end up being registered nurses working with health coaches. Is it someone navigating the system? Is it someone, what exactly is it do they do? Now, we've got some guidance from CMS recently that they will pay $42.93 for care coordination if you do it in their manner and encounters, a 20-minute encounter every month and resources for the patient. So I think some of it will be standardized around that effort and show some real value, but kind of defining what works best. We're not there yet. It's I hate to say we're building an airplane as we're flying it, but that's a little bit of what's going on.
Mm-hmm. Okay. And that kind of takes us to the skills and education that are required, and Tim, you start talking about in terms of the care coordinator and some work that the center and RHI had done previously,
yep.
Inventorying care coordination within rural health networks. Mm-hmm. We saw there was variability depending on if the care being coordinated was around behavioral health or chronic disease or pediatrics. So I'm interested in any other perspective in terms of providers, but even I think for both of you to share within the leadership at the hospital, to move to that value-based model, population health. What else are you seeing as needed?
Well, I think everybody has a different idea of what wellness means, what care coordination means. The one thing for me as a leader in the organization, I can tell you when we started going down this road, I'd go out and ask our providers and ask our nurses and ask our patients and community leaders, hey, we're going to do this. And it's so funny when I thought we were doing healthcare until we, and doing it pretty well until we started going down this road. Mm-hmm. And I'd talk to leaders in the community about this and say, all right, here's what we're doing. And they say, oh, well, thank goodness that Margaret Mary is now into wellness. You finally care about my health. I'm thinking, we've always cared about it, but now we're actively doing things. The change in the conversation has been palpable. I went up to our ophthalmologist not long after we started the program, and I say, well, how do you think this will impact ophthalmology? I mean, what I don't want to see happen is people live with cataracts when they really need cataract surgery. And I don't want to see it cut into that, and because you still want people to see. You don't want the idea of cutting costs to be so dominant that you postpone that. And he said, when all of medicine, this ophthalmologist told me, when all of medicine realizes the number of falls and the limited activity that come from people not being able to see well, you'll finally value my profession. And it sort of struck me as odd that this was his take on it. But every specialty, every group, every trained professional that we have feels they have a better role in wellness than what they are doing now. And it really changed the conversation I had with every leader in the community, from the fire chief to the ophthalmologist to the patient in need. And that conversation opened up so much more dialogue than we can ever address right now. But the potential is really out there. So from an education standpoint, there's a lot going on. Where it'll end up being targeted, I don't know. But my ophthalmologist is right. If I want to look at the cost that falls have, or the fact that people are not as active as they could be because of their lack of sight, I'll really look at ophthalmology differently.
Mm-hmm. Absolutely. Great. Thanks, Tim. Angie?
I have to commend Tim because, we're not there yet in talking with the communities. So it's nice to hear that perspective as we are just beginning the dialogue internally with our participating hospitals. And the engagement factor, and going back to something he had originally stated, was, really looking at the definitions and that everybody's on the same page. That has been key in the education because everybody had a different idea of what care coordination was, or community health, or, who was doing what. Well, we're already doing that. well, let's take a deeper dive. Are you really? So really looking at that was very enlightening for us just at the key concepts of this. New skills and education that we're also looking at for us is patient-centered medical home and the efficiencies of what that can bring to the table. While we're not pushing accreditation at this point, really just looking at the best practices from utilizing that model of care in the practice setting has been huge. We literally just had our kickoff meeting, and the energy was palpable. You could tell people are like, yes, we get this. Yes, we need this. And that was exciting to see that. Other things that we will be working on in the skills and education just for building our care coordination is, looking at reducing waste, using some lean training, understanding data analytics. That seems to be very key. Folks don't always know what that is, and really creating those roadmaps of how we're going to get there. It's, well, what's this mean? What's this mean? And how does that work? And building that model that people can understand is where we're starting at. And again, we're a lot newer and in our infancy stages as compared to Tim, so we do look to him as well, for the more advanced roles.
Great. Thank you. How about in terms of at the community level of the hospital and clinic interaction with the community? What challenges have you encountered, and maybe solutions to work through those?
Tim, you want to go first on that one?
Tim, I'll take a shot at this. The very first challenge is when we try, I think it's clarifying your message, clearly identifying to your message, to your community, what you're doing and why. Now, I will tell you the pushback you will get will be someone, now this is Indiana that I'm speaking to you guys from, so I don't know if any of you have people like this, but we have in our community what we refer to as Republicans, and there's a lot of them. And so when I come out and say this is what we're doing, my first question at the Kiwanis Club or at the at community foundations events, this is that Obamacare we've been hearing about. We don't want any part of that. So you have to be ready and be able to address that and say that, well, yes, this is something that was part of the legislation, but we have to take the legislation and do what's best for our community. And this piece is so there was pushback. I don't know if any of your communities have Republicans in them, but that was the pushback that we received. But we had to go back to the mission and very clearly tell what we're doing and why we're doing it. Now, I'll be interested in Angie's response to that. Since President Obama is from Illinois, I'm sure it was received much better in your communities than mine. But that was the initial reaction when I went straight to the communities. And that was over a year ago, so I'm not hearing it today, but it was the first few months.
And was that even at your board level, Tim?
No, it wasn't. The board knew what they wanted to do and why they wanted to do it, and wasn't even part of the discussion, because they were let's fulfill the mission with the tools and resources at hand. And I got zero pushback from the board. Great.
Okay. Because you prepared them. Yeah. Go ahead, Angie.
Yeah, we don't have any Republicans in the state of Illinois now, do we? For us, actually, our first introduction into the community has really been this Medicare beneficiaries engagement and onboarding. And we do hear a lot of conversation, oh, this is Obamacare, I don't want anything to do with it. Just in the introduction of our letter, of what we are doing, why we would like these Medicare beneficiaries to be engaged with us, and the outcomes with this, and it's the standardized letter that CMS has given us to utilize. We have standardized education flyers and posters in our practices now, And that's our initial introduction outside of just the board introduction into what we have started. So it is very interesting. Again, we're very much in our infancy stage. We have 15,000 lives within our MSSP. We've received maybe 150, not quite 200 declinations to be part of this so far, and we only have 2 practices that have yet to send out their letters of notification to all of the beneficiaries. So I think that's doing very well. As far as other comments we've heard in the community, there really hasn't been a lot yet, but we haven't pushed a lot as far as educating our communities on what we're doing. It is interesting to hear Tim say, well, oh, it's nice to hear that you're focusing on my health, or our wellness. And I'm thinking, I'm expecting to hear some of that. While we think we're doing it, we may not have done a good job of how we have really kept our community engaged in what we do. Back in the day, you used to hear about these rural hospitals as being, oh, that's the Band-Aid station. And we hope that, they start looking at the hospital as that is where we go for our resources. That is who's providing our care for our community. They have this X, Y, Z. So we expect to hear those changes coming, with our community members. But again, we're still early on, so it'll be interesting to, ask me in 6 months and I'll tell you a little bit more.
Okay. How about patient data? Why is that important, and what tips do you have to hospitals just starting down this path? Tim?
Yeah, let me start that. We received our data. We haven't quite had it for a year. Lots of things. The very first thing I will tell you is an increased level of responsibility for 2,300 people. That we now have all the medical information possible from Medicare on these 2,300 patients, and we're supposed to sort through it and figure out what to do better. So in looking at it, it's not, our team sort of looked at that and said, we're responsible for making care better for these folks, and what are the problems that we're getting out of it. I will tell you that ownership, that responsibility, although we feel like we've got a responsibility for the community, now it becomes more because CMS assigned these 2,300 people to us. So I think that was the first thing that we felt as a team. The other one is you have to realize you'll get so much data by being in the Medicare ACO program that you can't ever sort through all of it. But it's good data and it's good information. What it doesn't tell you is any answers. There's not a single answer in any of this data. But what does exist is the ability to ask better questions. That's what we have come up with the data. The very first number that came up is what our cost per Medicare beneficiary was. When the national average is somewhere around $10,500, our average cost per Medicare beneficiary was $7,900. So I thought, am I happy about that or am I upset about that? And I don't know yet. I've had that number for a year and I still don't know. The good part about it is I know our process is not wasteful. I know we've got an efficient process. The bad part is I don't think there's going to be a whole lot of shared savings that's going to come from it. If I was at $12,000 or $13,000 per Medicare beneficiary, I could get down to the national average or below and feel comfortable there's a lot of shared savings. When I'm 20% below the national average, or 25% actually, my ability to get down to 50% of the national average is kind of limited. So those are some of the first things you get from the data. The other thing is it sort of, asks you about when we compare ourselves with the California and Michigan hospitals, we use a whole lot more skilled nursing than they do. Now, is that a good thing or a bad thing? And why is it? And what do you do with your patients that have hip fractures, and what do we do, and how do we go about that? Another thing is you can look at the emergency department usage, and we all know our patients that are frequent into the emergency department more than others. you clearly get a list of those and you identify them, but it breaks it down by physician also. So I've got one physician that's a family practice physician. If you're a patient of his, a Medicare patient, you'll have a 78% chance of going to the emergency department this year. Another physician that practices alongside of him, if you go to that physician, you've got a 36% chance of going to the emergency department this year. So there may be really good reasons why that is, but it allows you to ask the questions. Which one has the best practice? How do you keep this from happening? Maybe one should be using emergency department more, maybe the other less, but it starts to send you down the road to ask better questions. And I think that's the value of the data that we've received.
Great, that's fascinating.
Yeah, and we haven't received our data yet. You know, we're still in the infancy. We're still getting our letters out to our beneficiaries. So we don't know what our data is going to look like. And then to really segment, identify those meaningful different groups of patients, you know, target them, looking at specific programs for these relevant segments and, you know, building the care, you know, that meets their needs, you know, to demonstrate, you know, a reduction in readmissions, you know, and the care provided. But again, we don't know yet where we're going with the data because we haven't seen it. So it's exciting to hear what Tim has said so far on what they know. You know, we're just preparing right now for the what if because we don't know, you know. We're looking at, you know, our specific disease management targets, you know, of your diabetics, your congestive hearts, your obese patient population. But again, we don't know. We're just hypothetically preparing until we get that first list and first grouping of data.
Angie, are you using past data from your EHR or secondary public health or claims data from your from Medicaid or any other sources at this point?
We've asked the hospitals to start looking at what they have currently, you know, from their current claims data. But again, we haven't collectively brought it all together. So it's just a matter of, you know, our hospitals learning to drill down in their data. What do they know? What are they seeing as their most prominent disease-specific diagnoses in their community and in their region? So we do use some of the state data that we have access to. But again, still being very early on, you know, we recognize the importance of data. Right now, we're just looking at, you know, how do you really interpret the data that you have? You know, what have you done internally? Start looking at some of the reports that you're capable of producing to begin looking at that segment and looking at what we can do to measure some improvements with that until we get that first blush. We anticipate our first CMS data population to come in probably in about 30 days, 30 to 60 days. And then we'll be like Tim, you know, that level of responsibility and the overwhelming ownership of their care, you know, is definitely going to come into play when you see those numbers and wow.
Yeah, one thing I can add to that is you start to see patients that one patient in particular, their average spend for ambulance visits for ambulance care per month was $260. Their average spend for prescriptions was $6. So someone's calling 911 a lot and not filling their prescriptions. So how do you, you know, and now you've got a responsibility for that. So how do you fix that? And we're still a democracy, so you can't mandate changes, but you've got to put things in place to help that that patient get better care than what they're receiving now.
Absolutely. Okay, our final question in this area around the solutions or types of partnerships within your community that you've both found valuable as you're adopting this value-based model. Angie?
Yep. So for us, we're really looking at the partnerships based on our community health needs assessment, who have we worked with through each community, because each of these partnerships may be a little bit different. And we want our members to essentially own their own processes, but really look at those partnerships. You know, how are they working with their physicians, both the employed and not employed? How are they working with their urban counterpart? The EMS systems, and what have they done in that realm, the local health departments, local senior citizen center, you know, to assist in educating them on what we are doing, you know, and what they are doing as a hospital, you know, to improve the care provided and to improve the community perception of care, and knowing that they are a resource for them, is where we have started with this. Again, you know, it will eventually go through with our wellness committee and the wellness initiatives, and how can we provide some wellness tools for our community members, you know, to improve the health and well-being of their employees. So looking at those local industries and what can we do as a hospital, you know, to assist in that realm. But again, we're still very early on, and we're just starting to, you know, touch our toes in the water, I guess you can say, in that, you know, as we go through the process.
Thanks. And Tim?
Callie, I've got about 10 hours worth of presentation on this. This has been one of the biggest things that has surprised me and impressed me about the entire process. Our conversations with community leaders and with different organizations, that we go to them and say, a lot of this is, we need your help to accomplish it, because it's like the ambulance prescription issue I talked about. That's someone that needs help with transportation. So we don't have a transportation service, and there aren't that many taxis in Batesville, Indiana, if you can imagine. They don't have dependable transportation, so who do we work with for that? And it opens conversations up with non-traditional healthcare providers that we've had. I can tell you one example. There's a group of ministers that meet in the county, and they've I presented to them, this is what's going on and what we're doing. They came back to me and said, years ago, before HIPAA and everything along that line, we used to have parish nurses. We'd like the hospital's help in starting a parish nurse program again. Would you do it? Now, before our focus on wellness, before the shared savings program, we might help if it's something we think is worthwhile. We might, you know, if we had good connections. But when we talk about trying to get screenings, people doing regular blood pressure checks, having a health resource in each church, and in a lot of our small communities, the only thing in this small town of 400 people is one church. So, you know, they're the social service agency for the community, but they've been standing alone. So now we have the conversation, and again, I'll go back to it changes the conversation. What efforts should we put in to make sure that the churches that want to have parish nurses have people that are trained and work with us and function with us, and what can they do, and how can we build and strengthen that? A program that was strong 15, 20 years ago in our community and now is not. So now we've got a bigger role in things like that, and that's one of, again, 10 hours worth of lecture I have on this, but has been a surprising number of people that want to be involved with us and want to work with us, that really, when we were the facility on the hill that you stumbled into when you have a medical condition, and turning our ship to be something where we want to keep people healthy and active and well, they want to have a different conversation with us. They could always make the referral to us in the past, but now that it's more of this partnership concept, it's been really exciting. It's helped me understand the hospital's role in the community much better.
And are you both finding that community partners are interested, although at this point you don't have funding to support their partnership efforts at this point, since?
Well, I think ours are very interested. They're still doubtful because they still think of us as the place to go when you're sick. So they wonder whether it's just the flavor of the day or whether we really mean it. Is the only reservation that's out there. But when we convince them we really mean it, and this is the first few steps in a very long journey, they get excited about it. And they're not looking at us for cash. They're looking at us for, like the parish nurse program. They want us to do training. They want us to help set up standards. They want to connect the parish nurses together. They don't want one just simply taking pulses at one hospital, at one church, and the other one trying to do surgery in the back pew. They want to sort of standardize what the parish nurses can do, and when they need help, who they reach out to. So it's not so much a cash thing. A lot of times, it's really a help in getting things coordinated.
And I'll tap into that same, that flavor of the month. Is this sustainable? And, building those relationships with the community. What are they doing this month, and are they going to change it next month? Looking at that sustainability over time and really building the trust is definitely key. But I see the interest there. You hear it, when we're talking with our hospitals and leaders. You're hearing this in the community. They just don't know what it is, that unknown, and what's it really going to look like right now for us.
Sally, let me tap into that one a little bit and tell you that one of the things that I see when we see hospitals that are financially struggling or financially in peril, one of the things that comes up is that the people have lost faith in people of the community have lost faith in the hospital. I think this has the potential for a lot of ours, when we build these stronger community relationships, to gain the faith of our communities back in places that you can't do with an ad in the paper or a billboard. So I think there's a lot more to this than just the wellness program we're talking about. But check back with me in a year and I'll let you know.
Okay. Well, I'd like to open it up to questions before we get into any final recommendations or lessons learned. And again, it's *2 to unmute your line, or you may pose a question in the chat box for Angie and Tim, or one of them specifically from their perspective. Any questions? I know we have some state partners on the line as well, from state offices and hospital associations and networks. So you can certainly pose a question from being a provider of education resources to your hospitals as well. I'm not seeing any questions, so I'll pose that question of what did, if you could each kind of name or cite 2 resources you found were most valuable for your hospital and hospitals within your groups as you adopt the value-based models. Can you share those, please? I'll start with Tim.
Yeah, I can tell you that it was great to go at it with a group of hospitals that were in similar situation to us. I mean, one of my colleagues really challenged me on this. He said, because there's a large tertiary hospital in our region that you can join their ACO. And he said, and he joined their ACO, and he said, this is great. They do all the work. If there's shared savings, I get a piece of it. I don't know why you guys would go out on your own. And I think, my answer was, one, it's an urban-based ACO. Two, they want you because they want their patients assigned to you, and they're going to get all the data on your patients. I think the value that we had and the resource we had is to, when I'm in tears trying to figure this stuff out, calling my counterparts in California or Michigan and saying, how did you do this? And knowing that they're facing the same challenge that I'm facing, where that doesn't happen when you have this kind of relationship with an urban or tertiary care center. So I think my best resource was other hospitals on the same timeline as us facing the same challenges.
Okay, great. Thanks, Tim. Angie?
And I have to say that same, our best resources were, internally our desires from our own hospitals that were interested in this, but then also looking at that National Association and Tim and what they have brought to the table from lessons learned, talking with others that are in the rural community setting, they've done this, and seeking some guidance and, their best practices in moving forward, I think was huge for us. And knowing that this is the right decision to do.
Yeah, I think one of the things that I will tell you, the very first meeting of this group, when we sat down together and formed the first meeting and said, do we put the application together by this ragtag group of hospitals? And we said, yes, we do, and we'll be very careful to take good notes, because if we fail and none of us are around to tell the story, that at least you could learn it from the notes. So the intention of the first hospitals going together and making this rural ACO application, we knew we were all taking a chance, but we also knew we all had a passion for making delivery of health care in rural and small communities better. So knowing that we might die from it, we still wanted everybody else in the country to benefit.
Absolutely. Okay, good. Well, I appreciate both of you sharing your lessons learned, and now you're becoming a resource for others. Do you have any final comments on lessons learned? Or what your final takeaway to others looking at moving towards the value-based model in population health?
My last statement is I would say that in discussions with CMS and the bulletins they've put out recently, it's very clear that Medicare and the federal government wants us to move down a value track, wants us to move down to away from volume and toward value into some sort of value-based model. So I think this is clearly going to be the direction they're going, and whether you talk, and I mentioned Republicans and Democrats before, but whether you talk to either party, they know they want to get more value out of the healthcare dollar that they're spending. They may disagree on some of the minor details, but they all want that. So I think it's going to be something we're all going to be faced with. It's not going to be the flavor of the month. It's not going to be something that's going away. I really think this is the direction that we're all headed. Trying to figure out how it fits best in your organization is going to be the key.
Okay. Thank you, Tim. Angie?
I have to agree with that. And for me, it's really, do some, I like to call it soul searching. What are your overarching goals as a rural provider, and how can you align and create that sustainability, in